assessment, radiographic imaging, chest X-ray, radiogram, röntgenogram. Many pulmonary problems will be detected on an X-ray before their presence is detected by clinical assessment, especially pneumothorax, foreign bodies, displayed tubes, etc. B. Normal chest X-ray radiograph. Both hemidiaphragm are rounded, dome-shaped. The right hemidiaphragm is slightly higher than the left. The right hemidiaphragm is at the level of the sixth anterior rib. Trachea is midline, bilateral radiolucency with sharp costophrenic angle. There's a chest X-ray PA view and then a lateral view. C. Quality of radiographic image. Head of clavicle should be level. Penetration. The degree to which X-ray have passed through the body. A well-penetrated chest X-ray is one where the vertebrae are just visible behind the heart. Exposure penetration. Proper exposure penetration will show the inverted disc space through the shadow of the mediastinum. An underexposed, underpenetrated image does not allow visualization of the intervertebral disc through the heart shadow. An overexposed, overpenetrated image will show black lung parenchyma without blood vessels. 3. The space between the vertebrae should be equal, visible, and distinct. A20. D. Anatomical landmarks, chest X-ray. Number 1. Trachea, seen as a dark area midline. Tracheal shift to one side would indicate a unilateral lung problem. The trachea should be the same size as the vertebral column. Major bronchi should not be narrowed at the carina or at the distal end. Narrowing may indicate bronchogenic carcinoma. 2. Mediastinum, the area between the lung where the heart, lymphatics, blood vessels, and major bronchi are found, may shift with the pleural effusion or pneumothorax. AP diameter, increased with COPD, barrel chest, hyperinflation. Costophrenic angles, angle made by the outer curve of the diaphragm and the chest wall. These angles are obliterated by pleural effusion. Diaphragm, dome shaped normally, flattened with COPD. Left to right hemidiaphragm may shift downward with a pneumothorax, appearing flattened on one side. Vascular marking, blood vessels, lymphatics, lung tissue. Heart shadow, left ventricle normally seen, cardiomegaly, enlarged heart is seen with CHF. Soft tissue, tissue surrounding the chest and above in the neck area. Subcutaneous emphysema occurs when air hyperlucency is seen in the surrounding soft tissue. Ribs, look for normal curve and spacing. Crowding of ribs close together is associated with atelectasis. Straight or horizontal ribs are characterized of air trapping. A21. E. Position/projection. AP projection. X-ray travels from anterior to posterior. Image receptor behind back commonly used to bedridden patients. PA projection. X-ray travel from posterior to anterior. Image receptor touching the chest with the patient's back to X-ray tube. Lateral position. Projection from either the right or left side. Adds a third dimension to structure viewed on AP or PA images. Oblique position, slanting or diagonal view, aid in localizing lesions. Lateral decubitus position. Patient laying on the affected side, valuable for detecting small pleural effusion. Apical lordotic. Projection of the lung apices. End expiratory image. Taken when the patient is at end exhalation. Valuable for detecting a small pneumothorax. Can measure diaphragmatic excursion. Position of endotracheal or tracheostomy tube. The tip of the endotracheal tube should be positioned A. Below the vocal cord, approximately 2 to 6 centimeters above the carina. C. At the level of aortic knob or aortic arch. Inspection and auscultation will quickly determine the tube position before a chest x-ray is taken. Tracheostomy tube do not pose the problem of main stem intubation, but rather positioning outside of the trachea. Evidence of endotracheal or tracheostomy tube cuff hyperinflation. The cuff should not extend over the end of the endotracheal or tracheostomy tube. Position of pacemaker, catheters, and other tubes. Pacemaker wires, electrodes should be normally positioned in right ventricle. Pulmonary artery catheter should appear in the right lower lung field. Central venous catheter are inserted through the subclavian or jugular vein and should rest in the superior vena cava or right atrium of the heart, fourth intercostal space, right of sternum. Chest tube should be located in the pleural space surrounding the lungs. Nasogastric tubes and feeding tubes should be positioned in the stomach 2 to 5 centimeters below the diaphragm. A22. Lateral neck X-ray. Number 1. Valuable diagnostic tool for identifying upper airway obstruction in children, that's croup or epiglottitis. Both conditions cause a localized swelling of tissues that may result in partial to complete obstruction of the airway and require prompt and effective therapy. A. Croup or laryngotracheobronchitis. The X-ray of the neck will reveal tracheal narrowing with subglottic swelling in a classic pattern called steeple sign, picket fence sign, pencil point sign, hourglass sign. Epiglottitis. A lateral neck X-ray shows supraglottic narrowing with an enlarged and flattened epiglottis and swollen epiglottic fold. Eri, oh my gosh, epiglottic folds. This presentation is known as the thumb sign. Sorry, this is blurry. The airway can be narrowed by edema, secretions, tumors, aspirated foreign bodies. Most of these conditions would be identified on an appropriate chest or neck X-ray. Extrapulmonary air, defined as air found outside of the lungs. Examples include pneumothorax, pneumoperitoneum, pneumomediastinum, pneumopericardium, subcutaneous emphysema. Presence of foreign bodies. Examine airway for an aspirated foreign object. Inspiratory expiratory radiograph are helpful in locating areas of air trapping. Majority of aspirated foreign bodies are radiolucent and cannot be seen on chest X-ray. A23. So this is boxes with terminology and description and diagnosis here. Radiology, terminology, and interpretation. So, for number 1, radiolucent, the description is dark pattern air, and the diagnosis is normal for lungs. Radio dense opacity, Description is white pattern, solid, fluid. Diagnosis normal for bones and organs. Infiltrates. Description is any ill-defined radio density. Diagnosis is atelectasis. Terminology for consolidation. Description solid white area. Diagnosis pneumonia, pleural effusion. Hyperlucency. Description is extrapulmonary air. Diagnosis COPD, asthma attack, or pneumothorax. Vascular markings. Description is lymphatics, vessels, lung tissue. Diagnosis increased with CHF, absent with pneumothorax. Diffuse. Description is spread throughout. Diagnosis atelectasis or pneumonia. Opaque. Description is fluid or solid. Diagnosis consolidation. The next box is about diagnostic, description, and interpretation. Pulmonary edema. Terminology would be fluffy infiltrates, butterfly pattern, batwing pattern. Description diffuse whiteness, infiltrate in shape of butterfly. Treatment would be diuretics, digitalis, and digoxin. Diagnosis atelectasis. Terminology would be patchy infiltrates, plate-like infiltrates, crowded pulmonary vessel, crowded air bronchogram. Description would be scattered density, thin layered density. Treatment would be lung expansion therapy, SMI, IPPB, CPAP, or PEEP. Diagnosis for ARDS or IRDS. Terminology would be ground glass appearance, honeycomb pattern, diffuse bilateral radio opacity. Description reticulogranular or reticulonodular. Treatment oxygen, low tidal volume or PIP, CPAP, PEEP. Diagnosis for pleural effusion. Terminology would be blunting, obliteration of costophrenic angle, basilar infiltrates with meniscus, concave superior interface border. Description would be fluid level on affected side, possible mediastinal shift to unaffected side. Treatment would be thoracentesis, chest tube, antibiotics, steroids. Diagnosis for pneumonia. Terminology would be air bronchogram. Description increased density for consolidation and atelectasis. Treatment antibiotics. Diagnosis pulmonary embolus. Terminology you're looking for is peripheral wedge shape infiltrate. Description would be maybe normal. Treatment heparin or streptokinase. Diagnosis tuberculosis. Terminology would be cavity formation. Description often in upper lobes. Treatment antitubercular agent. So basically what you guys are looking for on the test is these diagnoses. They're going to use the terminology and description in the question, and then you're going to either tell them what treatments you have to do, or they're going to give you the terminology and description, and you're going to have to tell what kind of diagnosis it is. Okay, everything that I'm reading in Kettering, every word is a potential answer. A24. Radiographic finding on chest x-ray. On number 1 is pneumothorax. Pneumothorax of the right lung, starting at mid diaphragm and moving upwards. Rib fracture on right at rib 3 and 4. Heart shifted to the left side, indicating possible tension pneumothorax. The picture of the chest x-ray is at the bottom. Oops, over here. this is the picture. That right here is a pneumothorax. This is the right lung. Acute respiratory distress syndrome, ARDS. It's gonna description would be ground glass appearance, diffuse bilateral infiltrates in all lung fields, and it's just gonna look like honeycombing or ground glass. Like literally, this is how it looks on real X-ray as well. Pleural effusion. Pleural effusion, right middle lobe. Right side blunted costophrenic angle and elevated diaphragm. This is not a good picture, but if you can see over here, the right side costophrenic angle, you can see it's not the, I'm sorry, not the costophrenic angle, but you can see elevated diaphragm. Diaphragm is supposed to be down here, but it's been elevated and it's over here. Okay, and you will see right-sided blunted costophrenic angle. There is no costophrenic angle. You see how it's pointed here? It's blunt over here. Right main stem intubation. This is how when somebody gets intubated and the tube goes into the right main stem, you're going to see that the patient is getting ventilated only on the right lung and there's no ventilation on the left side. So that's how you know it's a right main stem intubation. A26, patient assessment, other imaging procedures. Computed tomography. Let's. I'm gonna make this a complete separate video. So we are done with the radiograph, and I'm gonna read this section in my next video.